Thank you, Dr. Ghazi. And I would like to thank the organizers and all the supporters of this conference. So I was asked to talk about EvoShield for patients at risk for complicated COVID course. This is the agenda, so we will have 15 minutes. Unfortunately, I have 50 slides. I was hoping to get some more extra time, but apparently we're on time now. And then we will have 5 minutes at the end for questions and answers. These are the disclaimers of AstraZeneca about this product. And this is about, the indications, the label indication for the product. We will review these at the end. These are my disclosures. And as you know, about 2% of the general population in any country, about 2% of the patients are considered to be immunocompromised, and these patients will have or expected to have a dismal course with COVID infection. So these are patients, with hematologic malignancies or patients on active chemotherapy, solid organ transplant patients, dialysis, patients on immunosuppressant for other diseases like autoimmune disease, primary immunodeficiencies, and of course, COPDers and patients with primary lung disease. So these patients not only have an underlying condition, they do not respond well to the vaccine, to the COVID vaccine. And here you can see this study in different patient population, whether it is dialysis, solid organ transplant, or other immunosuppressive status. All these patients had a suboptimal response to the vaccination. Here you can see this is another study, large number of patients from UK. And as you see in red, it's the AstraZeneca vaccine. In the blue, it's the mRNA vaccine. And as you see, all these patients after the first dose have on average 50% response rate in terms of antibody production. After 2 doses, this response go up to around 80%. This is still well beyond below the normal population, the healthy control. Here in the dotted line, you see the healthy controls and their antibody production or their protection from vaccines after 2 mRNA vaccine goes up to 95 to 100%. You see here the distribution in these other status, like in cancer patient, barely it reaches up this line. The majority are below. Same in hemodialysis, same in organ transplant. As you see, this is the most severe among the groups, and probably because these patients are on continuous high level of immunosuppression to prevent rejection. And here you see on other immunosuppressive therapies. So what happens after 3 doses? Same again. So these patients would mount a response, and up to around 85% may reach a protective level. However, still it's lower than the healthy population, healthy controls. And as such, this population is at risk for complication. Around 45% of these patients will be hospitalized from COVID infection. And here you can see from this trial and solid organ transplant, higher hospitalization, a higher mortality as compared to the other normal patients. Now, the other problem that happened in this population is what we call viral evolution. These patients, apparently, they get the virus for a while, and as such, mutagenesis happen, and they can get evolution of these viruses. And this is why we saw some of these subtypes, Omicron, Delta, and the others. So the idea of EvoShield is to provide these patients with extra immunity by using normal antibodies. And as you see here, this is the composition of EvoShield. It is 2 antibodies modified in a way to increase the half-life up to 6 months and to increase the concentration of the antibody at the mucosal surfaces where the COVID vaccine entered the host. Additionally, these proteins or these monoclonals are modified in a way to increase binding to the what we call spike protein, which is responsible for viral entry into the cells. So this is the way it protects from these infections. So this combination has been tried in in different phases of the illness. The most advanced trials are PREVENT and TACKLE. PREVENT is a trial to prevent patients from getting COVID. So it is called the pre-exposure prophylaxis, and then the TACKLE is for early treatment of these patients. So here you see the PREVENT study. It was recently published in New England Journal. And basically, the objective was to see if this combination of monoclonals would protect patients at risk for dismal course with the COVID. Here you see the study design. So it is a phase 3 randomized double-blind parallel placebo-controlled study where adult patients were recruited and patients must have had negative serology at the entry of the study. And also the exclusion criteria were a history of COVID, positive SARS-CoV-2 at screening, prior vaccine or biologic therapy indicated for COVID, and of course, any allergy to drugs. So a large number of patients were randomized. And here you see the demographics of this population. As you see here, the population is enriched in patients at high risk for complicated course. 77.5% of these patients were classified as high risk for COVID progression. And more than half of this population were at risk population to capture the infection or exposure. Here you see the ethnicity and the race. Also here on the demographics, you see the subtype of vulnerable patients. So coronary vascular disease, obesity 41.7, chronic kidney disease, chronic liver, COPDers, and immunosuppressed patients. And here you see in terms of age, more than 43% were above the age of 60. And here you see the sex distribution. Again, so here the demographics, and here is a comparison between the treatment group and the placebo group. And as you see in both groups, the risk categories were equally balanced in between both. There was no difference in the baseline characteristics. Here you can see the primary endpoint, which is the reduction in the incidence of positive disease, symptomatic disease after either placebo or EvoShield. And as you see, there is a relative risk reduction of 76.7% with the use of the combination. And here also you see the relative risk reduction at 6 months after follow-up. So apparently, and again, because the half-life of these antibodies is 6 months, so the response and the protection is maintained up to 6 months. This is, again, you see the serum level. And as you see at 6 months, 183 days, the level is still in the protective level, basically because the half-life is a long half-life. Now, in terms of side effects, there were no difference between the placebo and the EvoShield. There was a concern about cardiovascular toxicity. However, after reviewing the data, no clear temporal pattern was found. And at the end, the FDA's decision was that there is no relationship between vascular events and the drug, and no causal relationship could be established. So as a result of this study, the drug was labeled by US FDA in December 2021 and was authorized for pre-exposure prophylaxis for a patient at risk for moderately to severe course with COVID. Now, of course, this was a year ago, almost a year ago, so real-world data started to emerge as well. And here you see a study from the VA, the Veterans Affairs in the United States. Also a large study where they did propensity controlling the cases with matched cases from the same institution. And they were looking at a composite endpoint of SARS-CoV-2 infection, hospitalization, and all-cause mortality. And again, EvoShield has proven to be effective pretty much at the same level as it was seen in the randomized trial. Now, moving on, this is the TACKLE trial. So the TACKLE trial is a treatment evaluation of EvoShield. So basically, it's a phase 3 double-blind randomized placebo-controlled trial comparing EvoShield to placebo to be given early on after symptomatic infection, and early on is defined as less than 7 days. So 903 patients were randomized to both arms, and basically the dose of the placebo or the EvoShield was given the earliest possible with the infection, and then the analysis was done in a way to look at patients who got the treatment versus placebo early on versus the ones who got it later on. And again, they looked at the primary endpoint of severe COVID or death from any cause at day 29, of course, to the safety and tolerability. And then there was some exploratory endpoints like respiratory failure, hospitalization, level of RNA in nasal swabs, so shedding of the virus basically, and incidence of antibodies against EvoShield. So this is the population. Again, so this was an elderly population, the majority of patients, plus the same as the PROVENT study. So it was enriched with patients at risk for severe course like chronic lung disease, obesity, hypertension, and so on. And here you see the analysis. So you see here that patients who got the drug versus placebo at 7 days had a 50% relative risk reduction in the composite endpoint, while patients who got it within 5 days of the onset of symptoms, the risk reduction was higher, 67%. And then patients who got it within 3 days of the symptom onset, they had 88% risk reduction. In terms of side effects, as you see here, so it is pretty much comparable to placebo. As a matter of fact, the number of adverse events were higher in the placebo group. And you see here the COVID pneumonia was higher as well in the placebo group. Now, going forward, how this drug is dosed, stored, and how it is administered, because this is very important for our patient population. So basically, the initial dosing that was studied for the preventive intervention was single dose of 300, so 150 milligram of each antibody, and each antibody in a different vial, IM injection. However, with the more data coming over and from the TACKLE trial, it turned out that the 600 milligram dose is offers better protection, and that's the dose that is recommended now. So 600 milligram, 300 milligram of each antibody. So these are monoclonals and have to be stored at 2 to 8 Celsius degree. And again, these are supplied in 2 vials. Each vial has one type of the antibody. The administration is IM injection. So this can be done in any infusion center. The patient can be watched for a little while to make sure no anaphylaxis happens, and then can be discharged from the infusion. So no need for admission. And it does not contain any preservative. So here you can see the emergency use authorization guidelines and where to use EvoShield. So it is labeled for adult patients who have moderate or severe immunocompromise. This is for prophylactic use. So this is pre-exposure prophylaxis. or patients in whom vaccination is not recommended due to adverse event or any other reason. Of course, these patients cannot be currently infected or had recent vaccine. So here you see that the alert of the EUA about the fact that this EvoShield is not a substitution for vaccination. If vaccination is available and no contraindication, patients should be vaccinated. Now, if you want to give it for a vaccinated patient, there should be at least 2 weeks in between the dose and the vaccine. Side effects, hypersensitivity, mainly anaphylaxis, bleeding disorders, and possibly this signal of cardiovascular event that was not eventually proven. So patients eligible, again, active treatment for solid tumor, hematologic malignancy patient, a patient who got solid organ transplant and taking immunosuppressive therapy, a CAR T-cell patient and stem cell transplant patient within 2 years of transplantation, or beyond 2 years but still taking immunosuppressive therapy, moderate to severe primary immunodeficiency like the George syndrome or Wiskott-Eldrecht, and advanced or untreated HIV infection. Here you can see the NIH guidelines about the definition of immunocompromised patients and the ones who should be prioritized in case of supply constraints of the drug. So you see patients who are within 1 year of receiving B-cell depleting therapy, and this is the majority of our lymphoma, myeloma patients, and in general hematologic malignancy. Patients receiving BTK, CAR T-cell, hematopoietic transplant, hematologic malignancies, lung transplant patients, patients after organ transplant, or recent treatment for acute rejection like T and B-cell depleting agents, severe combined immunodeficiency, and untreated HIV or uncontrolled HIV. So in summary, this is a monoclonal antibody against the spike protein, and it is protective for around 6 months. Eligible patients are patients with no prior COVID. This is for the labeled indication as of today, which is the preventive usage. So patients with no prior COVID and no recent exposure to known COVID-19 cases. They should be above 12 years old and above 40 kilograms with moderate to severe immunodeficiency. In the kingdom, so this drug is labeled for patients who are exempt from vaccine, on active therapy for cancer, who had a transplant within 2 years of transplant, or still on immunosuppression, solid organ transplant patient on immunosuppression, primary immunodeficiency, and advanced or untreated HIV. With that, I will finish and happy to take any questions. Thank you.